We're here again with Dr. Kevin DeCock, who has been with us for the last 6 years. This year, you're now, as I guess last year you took the post as the director of the HIV department at the World Health Organization in Geneva, Switzerland. Previously to that, you were in the Nairobi, Kenya with the CDC. We appreciate the work you've done, and we've always had these interviews over the last 6 years, and we're not going to really spend the time to bring us up to speed because that would take, you know, the rest of the conference time. So we'll just cover what you feel will be covered that are most important that are going to be covered at this year's conference. The first thing I think that jumps out is the work that began last year with the male circumcision. Can you tell us about what may transpire this year?
Sure, and good to see you again.
Yes.
Yes, Tom Quinn gave an outstanding plenary lecture last year on the prevention science concerning male circumcision. There's a lot of evidence that male circumcision protects against the heterosexual acquisition of HIV infection in men. And the really big news this year is that 2 controlled clinical trials conducted in East Africa, one in Kenya, one in Uganda, were stopped in December, stopped prematurely by the data and safety monitoring boards because of efficacy of the intervention. And just this week, The Lancet, the British publication The Lancet, has published 2 definitive papers from those trials showing that male circumcision had an efficacy of between 50 and 60% in preventing HIV acquisition in men. And this really is, you know, firstly, these are extremely well done and important studies, and they support the conclusions of another trial in South Africa about 15, 18 months ago. So this is really quite a coming together of data on this particular subject. I think there's going to be some discussion of that at the conference, and I believe there's a late breaker concerning side effects, adverse events from relating to circumcision and so on. Certainly it will be discussed.
So this was actually begun last year when Dr. Quinn did his work, and it was some question, but I think now you're saying that we're pretty solid on the evidence is there.
I think the evidence is extremely persuasive, and in fact, when you look at the science that's been done on this over the years, it's been done in a very logical and progressive fashion, and I mean, can almost be used as a teaching example of how one goes about establishing that an association between, in this case, male circumcision and lower rates of HIV infection in men, that association actually is causal. It's very persuasive, and in fact, WHO and UNAIDS will be organizing a meeting in early March to a big meeting of bringing in experts from partners from a wide variety of backgrounds to look at the science and discuss what the recommendations from all of this should be.
And then moving on to the other issues, we were talking earlier about the multi-drug resistant tuberculosis, which seems to be of great concern.
Yeah, there's a number of other things, I think, from the international scene being discussed. I think firstly what I'd like to say also is that the conference, the program committee of which I'm a member, made a decision that epidemiology and public health science now featured so prominently at the conference, relatively anyway, compared to how it used to be, that it would be appropriate to have another named lecture at the opening session, like the analogous to the Bernard Fields Memorial Lecture, which addresses basic science, as you know. So there's going to be, for the first time, a memorial lecture in honor of 2 individuals, Jonathan Mann, who everybody knows, but also one of his Congolese counterparts from when he worked in the former Zaire before he became the first director of WHO's global program. So there's a named lecture, the Ngali Mann Lecture, which is going to be given by Dr. Jean Pape from Haiti, who will be discussing his work in research and program relating to Haiti. And of course, he did some pioneering work on tuberculosis as well. Tomorrow, before the opening session, there's the International Symposium which you're aware of.
Mm-hmm.
And that there's actually 4 individual topics going to be discussed. Extensively drug-resistant TB, some issues relating to infant feeding, a presentation on mother-child transmission prevention, and a discussion on where we are with HIV testing. Mm-hmm. Let me just comment on TB and then hand it back to you for some other comments and questions. The reason to have a session on tuberculosis, of which there have been quite a few before in our earlier meetings, was the description last year, in August or so, of a very worrying situation in South Africa with tuberculosis highly drug resistant, resistant actually to not only to rifampin and isoniazid, which defines it as multi-drug resistant, but resistant to a whole series of other compounds as well, including the quinolones and at least one of the injectables. So this is extensive. This is referred to as extensively drug resistant, associated with very high mortality in the South African context, and affecting primarily HIV-infected people. And there were also in the initial description some healthcare workers who died. So this raises many issues. Firstly, it draws attention to the issue of drug resistance, especially in people living with HIV who perhaps have been kept alive by antiretroviral drugs and now are showing their continued susceptibility to tuberculosis. It raises the issue of transmission and infection within healthcare settings and the problems of infection control, particularly worrying as far as healthcare staff are concerned in high HIV prevalence areas. And just the need to continually address the issue of tuberculosis. Drug resistance in TB, of course, is preventable if we have closely monitored programs and good adherence. We shouldn't see the emergence of drug resistance to TB. But this is an issue for the future that we're going to have to pay very close attention to.
It's interesting, though. It seems to have taken so many years for the science world to really get a grasp on the enormity and the real possible problems of the multi-drug resistant TB. We've had activists and advocates that have come to our country here over the last 3 or 4 years, and I always want to interview them on HIV, and they always say, well, first let's talk about the issue of TB, which is even more important and even more concern for people. And I think they believed that there was more that could be done because they thought it was more treatable. But as we know now that we're getting the PEPFAR funds and that's being an issue, that you might want to address some of that. But that issue seemed to be something that was on their menu list back 3-4 years ago, and it seems like it's been drugged pretty heavily now into the science community to really possibly do something about it, at least pay attention to it, and see what we can do.
It's true, I think, that tuberculosis has not received enough attention. 18 years ago, 20 years ago, there was, of course, a fairly dramatic situation in the United States. In 1985, 86, for the first time, there was a decline, a halting of the annual reduction in TB incidence in this country. It stabilized and then it began to increase in the mid to late 80s. And then we saw all of the problems with drug resistance in New York City. And that, more than anything else, I think re-attracted attention to TB, increased funding and so on, and at enormous expense and great effort and very good public health work, the situation was gotten on top of, it was controlled. And in a way, we're sort of seeing a similar thing playing out in parts of the developing world, particularly in South Africa now. The concern is, of course, that, well, 2 concerns. One is that we don't really know how extensive this problem is, because you need the problem of multi-drug resistance and extensive drug resistance. Because firstly, you need a laboratory to be able to grow the tuberculosis organism and test for sensitivity. And a lot of countries don't have that. So patient dies, it's TB. We don't really know whether it's drug resistant or not. The other, I think an important point to make is that the rollout of antiretroviral therapy, which of course is a very desirable thing, actually has the potential to make the TB problem a lot worse. because we know with ARVs that patients, patients on ARVs still remain highly vulnerable to tuberculosis. Paradoxically, by keeping patients alive but highly vulnerable to TB, especially in congregate settings, they all come for treatment, and there are lots of patients around with TB, we may actually make the situation more complicated. Because previously, regrettably, patients would have died, but we wouldn't have seen this ongoing transmission and ongoing disease from tuberculosis.
Strains.
In a way, it does have some interesting analogies with the situation back in New York when we had a lot of transmission in hospitals, in prisons, in other congregate settings, and so on. This whole issue of infection control in hospitals, the prevention of transmission of TB in hospitals, in clinics, and especially the protection of healthcare workers, is definitely a whole subject that's going to have to get more attention.
Are we looking at maybe doing more presumptive treatment? I mean, you said that it's hard to get the science and the laboratories to do the work to really evaluate what is this we're looking at, or do we just treat presumptively and say, well, we'll do what we can
and that's difficult because we can't treat for drug-resistant disease based on presumption. I mean, that's just not possible. There has been some progress made in the treatment of sputum smear negative tuberculosis. As you know, the diagnosis of pulmonary tuberculosis is still largely made on the examination of sputum by microscopy. This is ancient technology when you think about it. This was technology developed in the 19th century. And we really need better diagnostics for tuberculosis. But one of the realizations with AIDS has been that a proportion of patients, quite an important proportion, have smear-negative TB, which is much more difficult to diagnose, especially in developing countries. And there's definitely moves to do better with treating that presumptively and to have better diagnostic algorithms.
It's just a shame because I know that in HIV, a number of people who I happen to know, like Paul Stoffels, made a broad thought, maybe we should just get the first-line regimen, second-line regimen, third-line regimen decided and just begin to treat rather than, as far as HIV, rather than to evaluate phenotypic, genotypic. All gets very complicated, which is something we do a lot in this country. But in some cases, not even as much as we should be. But then in the other case, looking at just going out there and treating people quickly and more quickly than we actually would advance, like before we would actually normally treat people. Here in this country, we want to treat people early. We don't have that luxury, I guess, in other countries, but he's thinking maybe this is the way, another way to be a little more preventative, as we have thought in this country as well, to prevent the transmission by reducing the viral load in people who are communicating the disease.
Well, TB isn't quite like that.
But he was thinking specifically about HIV.
Yes,
Yeah.
Okay, yes.
So are there any other areas that you feel might be of concern to be watching this year at the CROI?
Well, it's as always, it's rewarding for me from a public health epidemiology as well as a clinical background. It's rewarding to see more international work and more epidemiology and public health being presented. Just to highlight a couple of, I think, important plenaries, Dr. Harold Jaffe will be giving a talk about the epidemic in the United States. And one area I think of major concern, I really do think there's a need for a lot more discussion, is the issue of the ongoing epidemic of HIV amongst men who have sex with men. I mean, it is really quite remarkable when you think about it. More than 25 years into the epidemic, we have, likely resurgence of HIV transmission in this country, certainly increases in other sexually transmitted diseases. We've seen that in Europe as well. And there's now pretty good evidence from the developing world, from Thailand, for example, but also here and there in Africa, of significant rates of HIV infection amongst MSM. I think we need to have some very deep discussions about what we should be doing as a community, all of us together, affected communities as well as public health, the public health community, about how to do better with the epidemic amongst MSM. And I think it's going to require community leadership amongst MSM to say, look, this is we have to address this problem, because it is remarkable that, you know, compared to the early dark days of the epidemic when we had no treatment and the gay community felt completely under siege, there was a lot of you know, empowerment and incisive action by the community itself, which we've lost to some extent. And so anyway, that's one area that I think will spark some discussion. There's an important presentation by Professor Eggers from Switzerland on treatment outcomes in developing countries. There's been some very good work done looking at cohorts of patients in developing countries and seeing, you know, carefully monitoring how they do on therapy compared to patients in the industrialized world. And I mean, there's some very interesting conclusions. I don't know what his talk is going to be exactly, but from their publications last year.
As far as the buy-in and actually the adherence.
I mean, adherence was very good and outcomes are generally very good, but there's a problem of late diagnosis. So we have to do much better with HIV testing more widely, earlier, in healthcare settings particularly, you know, to improve outcomes. That includes for patients with tuberculosis, because early mortality is usually related to late diagnosis and, you know, the starting of treatment with very advanced disease. So I think will be an important presentation.
And you did say about mother-to-child transmission and pediatric issues with mothers who were
infant feeding is particularly.
Grandmothers taking care of their grandchildren. It's a pretty sad. We always talk with Médecins Sans Frontières, and that's one of their main concerns, and we always lament that issue every single year. It doesn't seem to go away. It just seems to be there.
Yeah. Well, obviously the prevention of orphanhood. Orphans are sometimes HIV infected themselves, often are not, because children who survive, you know, to grow up as orphans generally don't have HIV infection, because otherwise in developing countries where treatment in pediatrics is still scarce, they would have died. But obviously the solution to the prevention of orphanhood is to prevent infection or treat infection in mothers. There will be a discussion tomorrow at the International Symposium on why we're doing so badly with the prevention of mother-to-child transmission. And that's going to be, I think that'll be an important presentation. And there'll also be a discussion of the issue of infant feeding in HIV infection, which remains a very difficult subject, because, and we're really caught, you know, between a rock and a hard plate there, because in poor settings where access to clean water particularly is difficult to assure, breastfeeding is tremendously important to prevent diarrheal disease, and it also gives some protection against respiratory infections. On the other hand, breastfeeding is an important contributor to mother-to-child transmission of HIV. It accounts for, an additional 14%. In other words, if mother-to-child transmission around the time of delivery is about 25%, there's an additional 14% up to nearly 40% in cumulative then attributable to breastfeeding. So in other words, breastfeeding, you know, accounts for almost 1/2 of all HIV transmission to children, and yet it also seems to be you know, essential for children's growth and for their protection against gastroenteritis and so on. So there'll be a number of posters and presentations discussing these very difficult trade-offs, and the opening of that discussion will be at the International Symposium tomorrow.
I have just one more thought, and it is that we always hear about the issues of registration and availability, registration of the products in other countries, and the availability of the pediatric formulations and getting it approved for the other countries, because it is a huge responsibility. I know that we don't have as much going on in this country, so it becomes less important. But the pediatric formulation is extraordinarily important to get registered and be made available in other countries. Is there anything we as activists can do and advocates to push that in that direction?
I think to keep militating. I mean, to keep pushing both for both on the pharmaceutical companies, but also on governments. I mean, sometimes you know, sometimes it's governments themselves and countries that are very, very slow with their bureaucracies to, slow and sometimes not transparent with their bureaucracies to actually get drugs registered. So, you know, pushing on both sides is, I think, important.
We've lost an awful lot of activists that are activated in this country to other countries because they felt they maybe knew the ropes a little better and they could contribute some. And it's everybody trying to do what they can and spreading themselves much thinner than they should be.
Sure.
But I always appreciate you being here and telling us about the update, if you will, and at least the update at this CROI. And we hope every year that it builds a better prospect for the people, not only in this country but worldwide.
Good.
Thank you very much, Kevin.
Well, thank you. Good to see you.